Hello, welcome to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Each episode, we bring you a conversation with leaders across the healthcare industry, exploring topics ranging from new treatment techniques and interventions to novel service delivery methods and business models. And now your host, Rafi Salazar from Rehab Practice Solutions, a leader in patient engagement and retention strategy. Let's explore the possibilities of a new healthcare.
Hey, welcome to another episode of the Better Outcomes Show. I'm Rafi Salazar from Rehab Practice Solutions. My guest this week is a physical therapist who has been in the telehealth space for a number of years. I know tail end of 2020, telehealth is kind of old news, right? Well, I had this interview with him back in the summertime and just now getting around to posting it. But we talked a lot about not just telehealth in the sense of using it as a stopgap measure to sort of get patients in the door, get a revenue stream while patients aren't able to be seen during all these lockdowns that occurred in 2020. But really, we talked about how to make telehealth an integral part of the service delivery system at your healthcare facility. So we talked about things like cash-based services or out-of-network services. We talked about asynchronous telehealth, remote monitoring, that sort of thing. So hopefully you find this interview insightful and you can take some of the tips and tricks he gives to apply that into your daily practice. Again, Daniel Seidler is a PT and he runs a company called PT Solutions, and we'll link to all of his information in the show notes. I know he's got a course on like Telehealth 101, getting started and getting the systems in place and all of that. So that might be something you want to look into. And again, I'll put those links in the show notes on the post. Without any further ado, here's Daniel Seidler talking about telehealth in healthcare. Hey, Daniel, welcome to the show. How are you?
Pretty good. How you doing, Rafi? Good to be here. Thanks.
I'm doing all right. Well, for those that may not know you, tell us a little bit about yourself, your PT in your previous life. So talk about being a PT and then what got you into doing telehealth and now your company, right. PT.
Yeah. Once a PT, always a PT,
yeah.
Of course. I worked for a hospital for a few years, and then I owned my own practice for 15 years in the Bronx, and we had locations in the Bronx, New York, and Westchester, New York. Eventually, I partnered in 2016. I partnered with a larger group called Regional Group Motion Physical Therapy, and worked for them for a few years. I worked as a manager. I was director of business development, and eventually, I developed their telehealth, physical therapy, occupational therapy, and speech therapy programs. Put all that in place and worked on it for about a year, and left the company in September and started my own consulting firm. Motion was ready for the COVID moment when it happened. And I was ready as well. I had my policy procedures, had a whole system of doing telehealth for rehab practices. And a lot of people contacted me in that time to get over that hump, to stop the bleeding essentially, and, keep their practices operating. And at the time I had a lot of conversations with a lot of people about this being a telehealth being a long-term solution for physical therapy, occupational therapy, speech in their practices. It really should be an important component of what they do for the long term. And some have heeded that advice, and they're still rolling with it and doing great and really using telehealth in a lot of different ways in their practices. And some have not stuck with it as much. And I get it. I understand. I mean, I think it definitely was a good solution for a very intense short-term problem. But I still look at telehealth right now, particularly in rehab, outpatient, PT, OT, speech, as a really important component going forward. And, we've had this conversation before where I've told you, I think 20% of an outpatient practice should probably be committed to telehealth. And I know we're going to talk about how that's going to happen and all the different components of that and how telehealth can be utilized.
Yeah. Because during, the COVID crisis, a lot of people switched to basically telehealth using, Zoom and a smartphone, right? And you're talking
Yep.
down the line, or at least we should be building into our businesses telehealth as a cornerstone, right, of the treatment practices and delivery that we offer through our clinics.
Yeah, absolutely. And I think the practices that have expressed the most frustration to me are those that have expected telehealth to be a direct to consumer link for them. That they sort of expected to put. I think a few of them expected to put telehealth on their website and say, we do telehealth visits, we do virtual visits or remote visits, and because during March and April, patients were coming to them in that way. And I think that's happening less and less at the moment. I'm not saying that's not going to happen again in the future. I think that there'll be a big market for that, the direct to consumer PTOT speech. But at the moment, what I've seen work the best is practices that are they're sort of using their conventional means of patient intake and inflow of patients, referrals from docs and SEO marketing, word of mouth, repeat patients, things like that, and explaining to the patients how telehealth can be an important component of their regular plan of care. So, someone comes to them with a total knee replacement and the doc wants them to get PT 3 times a week. That patient can be doing, particularly if they're challenged with transportation and maybe shouldn't be in a PT clinic 3 times a week just because of the exposure, maybe other medical conditions and comorbidities, right? To reduce their risk and just convenience. Like, why not do one visit at one or two visits in the clinic and the other one remotely?
Yeah.
I think that should be part of all plans of care at this point and going forward.
Yeah. So that brings up an interesting point. So I've consulted in the space too, and I had some clients that have started businesses and have seen patients entirely remotely. They've never seen them in person. And then I've got some that have, they had a clinic before and then COVID happened and then they started doing kind of a blended model. Kind of your vision, you're saying, is probably blended is best, especially if you've already got a lead generation or patient acquisition system in place, right? You pull these patients in, then you educate them about telehealth and kind of use it as an adjunct.
Yeah, absolutely. And, the majority of my clients are brick and mortar, outpatient physical therapy, private owned physical therapy practices. And, they have their challenges now in particular, where, first of all, they have patients who who shouldn't be coming into the office on a regular basis. And they also want to minimize the traffic in tight quarters, particularly in urban areas where, real estate is expensive and, you don't have these lofty 5,000 square foot offices. They're kind of, there's always bottlenecks and tight spaces in offices. And, if you can minimize that exposure for a lot of people, I think it's really valuable.
Yeah. Yeah. So just from your own experience, then you'd recommend more of a blended model, or you think there's entirely virtual has its place in the healthcare space?
I think it has a place. I think, I think there are some patients, and I have some of my own patients, and I'm doing that 100% virtual. Like I don't have a
clinic space,
a physical office at the moment, clinic space, right? So I'm doing that, and it works for some patients. If need be, I'll refer them to a colleague, for an inpatient visit or two, or to continue their care with them. But some of them can definitely get along without having to ever come into an office. Sure. And I have clients, and I've spoken with plenty of people who are definitely pursuing that. They're pursuing this direct consumer, remote care only model.
Yeah, I guess.
How about you? Do you see a lot of people like that?
Yeah, I've seen. I don't see patients very much at all. I got something in the works to do some clinical work moving forward. After some of these big consulting projects wrapped up, but I have a mix. Some of my clients have started during COVID, so they started entirely virtual. One of them is in mental health and wellness, and then some of them have been people that have started mobile outpatient clinics. So I guess the vision will be they go to the person's house at some point. And then there's the brick and mortar folks that kind of have their referral systems in place, and they're just kind of using telehealth as an adjunct to it, right? So it's kind of a smattering all over the place. it's interesting when we talk about.
I think I think that's pretty cool too. I mean, it really opens things up for traditional private outpatient practices. And in previous years, in the past few years, I think a lot of outpatient practices have recognized the value in doing in-home care as well for some of their patients. Part B Medicare patients who can't get to the clinic so easily could use the services at home, right? You still bill it as Part B. It works. There's definitely a few business models out there that are doing exactly that. So, it opens things up. It adds to the flexibility of how patients can access us, and we can accommodate them.
Yeah. So from like just a regulatory or license standpoint, these clinics that are trying to go direct to consumer, obviously PT is probably in a different position because y'all have the compact, but occupational therapy, speech language isn't there yet. So is that a consideration? Like, are we advising clients basically to stick within your zone, your regulatory jurisdiction, or do you see anything in the future as far as updating that?
I mean, there's definitely a lot of people in this space in PT right now who are looking to take advantage of the compact. But even just get licensed in multiple states. You don't necessarily have to be in the compact to get a license in another state. It can be complicated. It can be a little pricey, but it's definitely viable. And larger groups there are definitely a few. I've spoken with a few. One private equity group in particular that is looking to get coverage in every state. And they don't necessarily need to have 50 PTs, one in every state. If you have one PT, and not to give away any secret sauce or anything, but if you have one PT who's licensed in a compact state, they can basically treat in 28 states now, I think, something like that. And then you just need to fill in the rest of the map. Which can be a PT can be licensed in 5-6 states at a time without being in compact easily.
Yeah, or they could contract with somebody that's
or more,
in that state.
Right? Yeah, exactly. Right. That's right.
Yeah, no, that's awesome.
Yeah. So that is happening. Yeah.
Awesome. So we talked a little bit about, I think we're kind of broaching into the subject now, like all that PT or that telehealth can be for rehab. So in the space, telemedicine and telehealth has kind of been thrown around forever, but really in rehab, it's primarily been used synchronously, right? Like you and me are on a Zoom call right now, chit-chatting, and this is how telehealth is happening in the rehab world. But what kind of options should we be looking at, and how big should we be thinking?
Well, I think first off, asynchronous is such a cool option. I think you can do so many things with it, and there are third-party payers, insurance companies, Medicaid programs that are covering asynchronous physical therapy and other rehab services. And to me, the most obvious thing would be, and I'm working on a model with a client that we haven't really pulled the trigger on it yet, but the idea is essentially send either a video to the patient asking them what to do with cues for them, or basically, or even just a text questionnaire. So what I want you to do is I want to see you, and you can basically run them through a McKenzie exam, for low back pain, or, if they're having shoulder pain, let me see you do shoulder flexion, turn to your side, show me shoulder flexion, stand straight ahead, show me shoulder abduction, things like that. And basically, functional movements, you can basically run them through an evaluation and have them record it. They send it back to you. You can do an assessment and figure out what else you need to see, and, basically tee up a synchronous visit for the next visit. So the things that you didn't get from that asynchronous visit, you're all ready to go. And point is that the PT and the patient do not necessarily have to be in the same place or at the same time on the evaluation.
Yeah. How does that work with reimbursement? Are there payers that are willing to pay for that?
Yeah, exactly that. I know that in New York State, New York State Medicaid pays for asynchronous visits.
Oh, awesome.
And I know that there are others. That's the only one I know off the top of my head, but I know there are others, and there's definitely a push. A lot the telehealth lobby is definitely pushing for asynchronous as part of coverage, and it's very prevalent in areas of medicine like radiology, for example.
Exactly.
I mean, right? The patient's nowhere to be found.
Yeah.
They're nowhere near the visit when the radiologist is reviewing their X-rays or MRIs, any of their films. So it's a matter of getting that approved for PT and rehab.
Yeah, and I guess getting CMS to kind of matriculate that down to the other. Everybody falls in line behind them.
Yeah, and it's interesting. I don't know how. I'm not sure on the insurance side how deeply that is assessed, or how much it's really thought through when something like that is passed. It may just be a rubber stamp, basically.
Yeah.
There's with the idea being like, okay, we've done synchronous for a few months and that's working out, and all the stats and all the reports and studies are showing that it's as effective or more effective than in office. Asynchronous is working in certain areas of medicine. Maybe it'll work. Let's try it in the other areas of medicine. Yeah, let's test it. So maybe that will happen. I'm not really sure where things are with that.
Yeah. So I'm starting to think now, because now I'm thinking about asynchronous and the opportunities and assessments and all that. Let's back up a little bit.
Yeah.
So just from, let's say somebody's starting out and they're kind of intimidated about telehealth in general. You've kind of talked about walking through an evaluation over telehealth, but what are the main components that make it different? I mean, obviously you're not in the room, you're not touching a patient, you're not taking measurements. Sure. So how do you make an adjustment as a clinician?
Yeah, I mean, first of all, a lot of the assessment has to be about the subjective. Uh-huh. So it's about this communication. And, I think we all know, any experienced therapist or medical professional knows that you learn a lot about what's going on with the patient from your conversation with them, from your subjective assessment. And then your physical exam essentially is a confirmation or a rejection of what your hypothesis is from what they're reporting. And sure, patients may report some things that aren't 100% accurate. They may be a little bit subjective to them, but as you're more experienced practitioners, definitely know how to guide a conversation, listen for certain cues where the patient may or may not be tuning into exactly what's going on with them, and follow up in that way. So I think medical practitioners who have done telehealth for 3 months, 4 months, or longer than that, over the years, have learned those sort of skills and have gotten a lot better at it in a short amount of time. Just recognizing that you have to use your other senses, essentially. Uh-huh. You can't touch the patient, right? It's like, and I used to do this before I started telehealth. I was a skeptic, like a lot of people are, and for my own purposes, I would occasionally treat a patient, particularly someone who I knew. I would do a treatment or try to assess them without touching them during a session, and I wanted to see how I could do. I want to see how effective I could be during a session without touching them. And, you first of all, you learn a lot just by doing that.
Yeah,
and
exactly.
I recognize that it's just not, you don't have to put your hands on a patient every visit to be effective.
Yeah. And that speaks to the whole idea of like passive treatments versus active treatments. And I said this a little bit ago, like sure. One of the great benefits that I see in telehealth is that it's kind of put that constraint on us, right? Like we can't touch a patient if they're on the other end of a computer screen. So it's making us kind of rely on those high level, like high value, high impact services that we can offer, those real skills, right?
Absolutely. Yeah. I mean, look, we bring a lot more to a visit, an encounter with a patient than just our hands. And sure, the tactile component of treatment is extremely valuable, but the other components are our knowledge, our problem-solving skills, our compassion, and our other communication skills, verbally and orally, just listening,
Yeah. It all seems to come back to those soft skills, the interpersonal
Yeah.
skills.
Look, I mean, I think every PT has known another PT who's a wizard with their hands, but doesn't necessarily communicate very well with their patients, and they're not always as effective as someone else who's a really good communicator and is very compassionate and just has a good knowledge base and problem solving ability.
Yeah. No, I couldn't have said it better myself. That's awesome.
I mean, that patient connection, that practitioner patient connection is so important.
The therapeutic alliance, right?
Yeah, that's right.
So, all right.
Great.
So back then to telehealth and some of this asynchronous stuff. So let's say you're wanting to implement telehealth, you're wanting to do it more long-term, you've got a vision, you want to be innovative. What's out there besides asynchronous, or are there things within the asynchronous? Because I'm thinking like AI and ways to integrate tech. Have you been working with any of that stuff?
I have, I've worked with a few technology companies who are doing those sort of, who have those sort of programs. I wouldn't say my area of expertise is in, and that's sort of differentiating into the area of virtual care, right?
Yeah.
Where it's, there are companies out there. There was Reflection, which I'm not really sure where they are right now, Sword, and, they have AI-driven programs that essentially progress a patient through a program. I don't know if it's not considered a protocol. It's really an evidence-based program of care, right? Based on the patient's response and based on their outcomes from previous visits, it'll progress them, and they'll have a PT monitor a slew of patients, maybe 50 patients over a week or so.
And that's not really telehealth. That's more like AI-driven
virtual health. Yeah, and I think that it's important that PTs and eventually patients understand the difference with that. It's a different road to go down, and I'm unsure about it. I definitely don't poo-poo it. I mean, I think that there's going to be a place for it. I think that that's something that's probably going to happen. Think of the economies of scale and think of the cost savings and all that. So I'm sure some payers will love that sort of thing. I don't know. I'm not sure what the outcomes are like. I'm not sure what patient satisfaction is like. I from everything that I've seen so far, it's pretty close to care from a person-to-person care. I don't know. What do you think about it? What have you seen in that space?
Yeah, I think, I've talked to a couple companies kind of in the same space working on AI-driven healthcare, but it always seems to hinge on, it's very difficult to get, like when you're building something for like the average low back, if you've read the book, the what is it, The End of Average. So he talks about taking 10,000 measurements of airplane pilots, and none of them were 10 out of 10 on these 10 metrics. So if you think about that, all these AI driven and virtual health platforms and programs are more or less built towards typical outcomes and typical individuals.
Average, right.
Yeah. So if you're building for the average, it's probably there's going to be some people that slip through the cracks. So I'm always kind of, it might work for a lot of people, but there's going to be some people that need some individualized, insight or adjustment or something. So.
Yep. I mean, it's, based on how healthcare is evolving at the moment, I don't doubt that it will be a part of the picture, a piece of the puzzle. I think those companies will probably find a market. I think there'll definitely be a demand for the low cost, high volume sort of AI driven care. I don't think it's going to replace 100%. It's not going to replace human care and human interaction.
Who knows? Maybe it might be one of those things that kind of takes all those low level, patients off of the schedule and frees PTs up to work with, patients that really need more, more
Sure,
complex, more
sure.
intense treatments.
Yeah, and I think that's part of the argument for it, for sure.
Yeah.
Yeah, to free up the practitioners for the patients who have more of a need. Yeah.
Yeah. The more of it
Makes sense.
All right. So how does in the telehealth space then, how does treatment change? We've kind of talked about running through a treatment without touching a patient. So what might something like that look like? Let's talk about synchronous first, and then we can talk about asynchronous after that.
Sure. I guess from an assessment point of view, as I said, I think the subjective is vital. Yeah, the manner in which you assess a patient is very important. I mean, it's really important that the patient understands that their positioning and their angle and the view of where they are is very valuable. I have a patient that I'm taking care of now she's a kindergarten teacher, but she seemed to always like understand where to be in front of the camera, and she like got her the volume is always right on her computer, and she turns to the side before me even asking her when I want to see her do flexion. I'm like, and I asked her just yesterday, I'm like, how do you know like this positioning? So like you always seem to like have an intuition for it. She's like, yeah, I was an actress before, so I did a lot of I did a lot of work in front of the camera before I was a school teacher. I was like, all right, that explains it. And a lot of patients do not, though. A lot of patients don't get that. So it's really important that PT or the OT or OT, explain to the patient that the plane and the angle that they're on is really important for us to be able to get a clear assessment of what's going on. And there is a study out there about range of motion during a telehealth visit, a remote visit, that shows that if you put a joint on the same level as the camera, you can essentially get an as accurate a goniometric measurement on the screen as you can in person.
Oh, okay.
So if you're measuring someone's shoulder flexion, for example, right? So I'm like right there, right? I go like this, and I know I'm not in the camera, I'm not back far enough.
Yeah.
But if you put a goniometer up to the screen while I did that, you'd be able to get an accurate measurement of my shoulder flexion.
Oh, awesome. So from that angle, then you could get those objective measurements and you can set those goals, right?
You can, absolutely. And there's there are definitely things that are harder to measure than others. Passive range of motion is one. Strength is another. Strength, I mean, you're typically measuring functional ability, functional movements more than manual muscle testing. And we've been told for years that we should be
doing functional,
setting functional goals. Anyway, maybe someone knew that this moment was going to come.
Exactly. Yeah.
And special tests. There are some special tests you can do remotely, but for the most part, they're not quite as accurate. When it comes down to it, most patients, I've found that I can be very effective with most patients by doing a virtual assessment and treatment. Some patients definitely need to be seen in person. They need an in-person second opinion, whether it be from me or a referral, someone to refer them to. But I've found that patients are getting better. PT's working this way.
Yeah. The outcomes are there, right? So it leaves something.
Outcomes are there for sure. And I'm curious to see. I mean, there are definitely some studies that are ongoing right now. I know the private practice section of the APTA is collecting data, and there are other groups that are collecting data on outcomes during the telehealth during the pandemic. So we'll see.
Yeah,
we'll see. And I know payers are very curious to see what they look like too.
Yeah, I kind of feel like this period of time is kind of them data gathering, right? before we get any big decisions about whether or not it gets covered at a private insurance level.
Yeah, that's true.
So how about asynchronous treatment? Would it kind of follow the same script as almost an assessment where maybe you're having the patient do some exercise or do some activity and then you're providing feedback?
Yes, that's almost exactly it. I mean, there's plenty of opportunities there. Certainly in the rehab space, you could do that where the patient records their a set of exercises that you give to them. They record themselves doing that. You give them feedback. There's also in the performance area or return to sports, recording a patient recording themselves running on a track or hitting a baseball or their tennis swing. And these are things that people have been doing forever, or at
Yeah.
least, in the last 10, 20 years. It wasn't called asynchronous telehealth, but that's what it is. I mean, it's another version of that. There are definitely other applications, and I'd like to see some other. I'm sure there will be other ideas that come down the pipeline on how to do things like this. Asynchronous can also be used in workplace assessments, ADL environments, home environments, things like that. Have you utilized any asynchronous
No, all the stuff we've done has
components
been
yet?
all synchronous. We set up the operational guidelines for the state of Georgia's Department of Behavioral Health and all of that. You're dealing with staff and provider residential agencies who either don't have the time or don't have the experience to try to set up something, record it and send it to you.
Right.
So it's been a
Well,
little
my
different.
contention on that, Rafi, is that it might actually be more time efficient for them to do it that way. To record something on their own time
Uh-huh.
and then be able to get it to you on their own. Whenever. Yeah, whenever. Exactly. So you send them an outline, and by get me a video by Friday, and we'll give you a response on it.
Oh yeah. No, that's a great idea.
There could be some value in that. I don't know.
Yeah. So outside of, I'm thinking like what telehealth can be and asynchronous and kind of the doors that opens up. What about things like, and maybe you're already working in this space a little bit, but where it's PT or it's OT, but it's kind of medically based wellness or something like that, where you could pull people into like a group program and then maybe individualized sessions. Have you been seeing any of that happening in the space?
Yeah, I mean, one thing I really like is, and it's not asynchronous, it's synchronous, group therapy sessions, particularly for seniors. So
like fall prevention or something.
Yeah, exactly. Fall prevention, or not necessarily for seniors, but like a back group, a lumbar or back pain group, Parkinson's groups. There are definitely groups that are doing that, and a lot of them had done. They had done, like one of them. One of my practices has traditionally done a Parkinson's group in their office, but they're trying to avoid that, and a lot of their patients don't want to come into the office. They don't have to wear a mask if they're at home. They can be and they can be in the same group setting, that social setting with their other classmates. The other people that they had been doing their program with before.
Yeah. How about
as far as asynchronous? I mean, you asked about that.
Yeah.
You certainly can do recorded classes. I'm not sure about reimbursement for that sort of thing, but it's great ideas. I mean, there's no reason why. And you could do a component of asynchronous and synchronous, like a weekly class, and then the patient have like a one-on-one with the instructor or with a PT after or before.
Yeah.
Sure.
Because I'd imagine, at least going forward, while a lot of the reimbursement stuff kind of settles and the dust kind of comes down from it, some of the people that are doing the innovative stuff are going to be in the private pay and the cash-based system, right?
Yeah, I think so. I think so. I mean, I think there will be payers, and possibly even Medicare, who pay for things like this, synchronous, asynchronous, and remote patient monitoring, even in the rehab space. But there will be some payers who won't pay for it. So I think it's an opportunity to build that cash practice a little bit, because there's there is, I think there's a recognized value in it. A lot of patients have realized it, and providers have realized the value in being able to offer services basically at will. When a patient wants it, and they don't necessarily have to get to your office to be there with you.
Yeah. No, I like the idea of getting almost not entirely away from insurance, but to the point where, a good bit of your
Yeah.
clinic or business is coming from, call it direct to consumer, call it private pay, whatever you want to
Yeah.
call it, is very valuable for businesses.
Yeah. Yeah. I agree with you that I think it's an important component of every practice. I think we have a little bit difference of opinion in how much
Yeah.
practitioners should be getting away from insurance.
Uh-huh.
And call me old school, but I've always I've always operated in a third party payer environment. So I'm fairly comfortable with it, and I think it's realistic for a lot of patients. It's much more realistic for a lot of patients. I understand that copays are going up and coverage is going down and reimbursement is going down, and it's a challenging environment. But practitioners definitely have to pick their spots, and it is important to have a cash-based component to every practice. What do you sort of have like a number or a percentage of a practice that you think should be cash-based?
Yeah, I think it depends on their target market, right? So if they're in the elderly space, you're already dealing with Medicare, and it's not like you can opt out like a physician. So that obviously changes what you can do. But I mean, I've had some clients that have been in like the sport and performance space that have moved entirely 100% cash based. They provide their patients a super bill and they submit for reimbursement. And at some level, I feel like, that's such a great model just from the standpoint of incentives and making sure that the incentives between the clinician and the client are aligned, because the patient is paying you directly. So there's that incentive there, as opposed to I'm treating you, but I'm really worried about what your insurance is going to pay. But at the same time, I work and have consulted in the spaces of like behavioral health and developmental disabilities where people just can't afford that, so it's there are people that if everyone went to a cash-based model would not receive services unless the businesses are set up to offer some kind of pro bono work or something. So I think it's got its place. I think for the general practice out there, 20% coming in private pay would be a nice little revenue stream that you can operate from.
I agree with that. For sure. And depending on obviously the population you're working with, the socioeconomics of your community, it's more realistic, and maybe you can bump that number up to 20, 25, 30%, 40%. I have traditionally worked with elderly patients, orthopedics as opposed to sports. So there's always a dependence on a third party payer, and that's the environment that we're in. What really interests me is more value-based care, and we're seeing that there are some groups that are succeeding in that arena, and they've done it because they have proven that they're going to save money for a system.
Yeah.
I don't know how prevalent it's going to be in the next few years, but eventually, and this is what all the telehealth people talk about, is how valuable telehealth is in a value-based system, because it is efficient. It's a way of connecting with a patient without a significant time commitment on both sides. Right? If a patient comes to your office, typically it takes them at least 30 minutes between their transportation back and forth, travel time, and usually more. Figure an hour, half an hour on both sides, maybe, or more. You can't, even if they just need 15 minutes with you, even if that's all they need for that day, it's almost like it wasn't worth their time like they traveled an hour for 15 minutes. It's kind of like, like that does not align for the patient. So, I've always felt uncomfortable about that. But telehealth makes that much more realistic. Like, we can get on, if all you need is 15 minutes of my time today, we can do that. If you need an hour, we can do an hour. We'll schedule it either way. but also it allows for more frequent touches with the patient and maybe in shorter bursts, right? So more frequent, shorter sessions can be very effective for a lot of patients. I mean, how many times has a patient come to you and been like, I felt great after I left you. I felt pretty good the next day. And then for the next 2 or 3 days, my shoulder was killing me, and I wish I was able to get in for an appointment with you.
Yeah, no, exactly.
And all it was about was their positioning, or they just needed a few minutes of your time or advice or a particular stretch to loosen things up.
Yeah, exactly. No, I like that idea, the shorter bursts. So value-based care, when you're talking about that filling, are you talking about the reimbursement model, like a value-based reimbursement or outcome-based measures, or?
Ultimately, yes. Ultimately, it is definitely about reimbursement models that are based on. I spoke with the CEO of a group in Colorado this week, and they've partnered with a primary care group in Colorado, and they essentially have negotiated their rates on the medical side of care. So they're not negotiating with an insurance company as an ancillary practice, getting paid on a fee for service basis. They are part of the medical team essentially, and they ultimately get paid about $200 per visit because of that. Now they're not getting a check for $200 every time the patient comes in, but they do get a check for $1,000 or so. Let's say after the patient does 5 visits, or the patient has come in, done 5 visits, and walked away with a good outcome and been healed, and they'll get $1,000 for that. Meaning that they're paid for the full length of care.
Yeah, they're getting paid basically for the project, if you would, like
exactly,
per engagement,
exactly.
as opposed to per treatment.
That's a great way to look at it. And with that, and maybe those 5 visits, maybe there's a couple of telehealth calls sprinkled in as well. Whether it's a phone call or a video visit, or whatever, or an asynchronous video comes to them, and they see the patient hitting a tennis ball, and so that they're prepared for the next visit, things like that.
Yeah, that's great, because then it is like you're pulling away again, that the incentives are lined up, right? So I'm not incentivized to only treat you or only give you my time when you're in front of me, and I'm billing for my minutes, basically, right?
Yeah, and exactly. And look, I'm hoping that some of the larger PT groups are looking at things in that way. I think for the value of PT and OT is going to be significantly increased when there's an understanding of how we can save money in the system.
Exactly.
And we save money in the system by being the first medical practitioner that an injured person sees in many cases, right?
Yeah.
If they go to a surgeon first, what happens?
Yeah.
They're now their care is being guided by that surgeon. And it's, all intentions are good, I'm sure, but their interventions are typically significantly more expensive than our interventions, and not necessarily better outcomes in a lot of cases.
Yeah. There's a great book out there called Surgery, The Great Placebo. Have you read it? It's a physician that he's a surgeon that talks about kind of like how outcomes post-surgery aren't any better. Oftentimes, depending, like those chronic low back pains, they have a back surgery and they're still in pain 5 years later.
Sure.
Yeah, I love the idea of value-based care. I think it's hard to wrap my head around it from a standpoint of understanding like value and the whole emotional contribution of value, and value is very subjective, and there's always different priorities and alignments within organizations and stuff. So it'll be interesting to see how they pan out over time.
Yeah, for sure. And I think there's a lot of there's definitely pressure from different sides on how it's going to play out. Everybody has their agenda and their incentives. We all know that hospitals make a significant portion of their revenue from elective surgeries.
Exactly. Yeah.
So they're kind of disincentivized to reduce the cost of care.
Yeah. Well, especially if they don't if they're referring out to rehab clinicians or clinicians that aren't within their system too.
Yeah, exactly.
So, alrighty. Well, are there any last minute thoughts you'd have about telehealth, about what you want maybe someone listening to know about the value that it can provide or the options out there?
Well, I said this before COVID, and I stick to it. I think that there's tons of value in telehealth and most of my perspective is from a private practice point of view. For OTs and PTs, there's opportunities for triage and initial engagement with patients, for engagement with patients, for actual care, assessment, treatment with patients, and I think it's another avenue to connect with your patients and providers and referral sources, and we should all be utilizing it in some capacity. It definitely takes a commitment. It's, if you have like one guy at your office who's the telehealth guy, it ends up kind of being just like a new piece of equipment in the corner. It should be a part of every practice. Front desk needs to be educated on how you're going to utilize it and how valuable it is. Your practitioners need to be educated, your referral sources, your patients. So, it's important that every practice is communicating that as part of their PR, their marketing, and, not just like a little blurb in the corner of your website, click here for a telehealth visit. It creates efficiencies and creates opportunities within a practice.
Yeah, no, that's great. It's got to be part. It can't be an afterthought, right?
Yeah. It should be interwoven in the practice, for sure.
Well, thanks, Daniel, for taking the time. Where can people find you?
First of all, thank you, Rafi. I appreciate it. Always great conversation. We've had a few of these already, and it's always great talking to you. I love your insight, so it's great. My company is TelePT Solutions, and the website is www.teleptsolutions.com. And you can email me also, dseid@teleptsolutions.com. Anytime. I always look forward to conversations about telehealth and how we can improve specific practices or improve the whole healthcare system in general.
Yeah.
It's really exciting to me.
Yeah, and you've got a course, right, on your site about telehealth, getting started, right?
Absolutely. Yeah, that's right. That's great. Zero to Launch, which is a course for physical therapists and practice owners on some of the logistics of starting as a PT, as a telehealth physical therapist, or occupational therapist for that matter.
Awesome.
Absolutely.
Well, thanks, Daniel. Have a good one.
Thank you, Rafi. Appreciate it.
All right. Well, I hope you enjoyed that interview with Daniel Sadler from TelePT Solutions. It's funny, you go into these interviews sometimes thinking you're going to talk about a certain topic, like in this case, telehealth. And it's funny how the conversation tends to glide into other areas. We talked a lot about value-based healthcare and different pricing models and subscription and how much of your business should be, out of network or direct pay versus insurance based. And we even talked about what is value and the subjectivity of value and all that. So I love having these kind of conversations. It's great. It opens up your knowledge base, if you would, to a wider range of viewpoints. Otherwise, that's all I've got for this episode. If you like what we're doing here, head on over to iTunes, give us a rating and review. It helps people find the show, helps people see us and think we're cool and come listen to us too. If you want to get notified whenever you drop a new episode, you can head on over to www.betteroutcomes.show and sign up there. You can also browse all of the other interviews and articles that we've dropped to date. Again, that's www.betteroutcomes.show. Until the next episode, guys, be safe, be healthy. I will talk to y'all then.
Thanks for listening to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Our hope is that you walk away from each episode informed, equipped, and empowered to push the boundaries in your own practice or business. We want to give you the tools to help you build strong, long-lasting relationships with your patients and clients, helping meet their goals, improve their health, and achieve better outcomes. Learn more at www.betteroutcomes.show. rehabupracticesolutions.com. We'll catch you on the next episode.